thank you. I'd like to invite Dr. Ashwin to present the next session. Thanks, guys.
Thank you so much.
Thank you very much.
Thank you so much.
Thank you.
Wow, guys, that was something spectacular. I think if you don't learn scleral fixation after that, it's going to be tough, boy. That was a phenomenal session. Thank you, guys, moderators and speakers of that session, scleral fixation. Moving on to the program now, I asked a question, and can we have the video to one of our moderators, and that was Priya Narang in this case. What technology are you looking forward to most in the post-COVID era, and why?
Presenting here is the Advanced Vision Analyzer. It comprises of a head-mounted device similar to a virtual reality headset, a patient response pattern, which is a handheld device, and an Android tablet that serves as a controller to perform, record, and analyze the test program. The head-mounted device is lightweight, and it allows a high degree of flexibility in patient position. The HMD is battery-powered, has an adjustable headband, and records the patient's response after the presentation of the stimulus. During the test, the system obviates the need to occlude the fellow eye. The patient response pattern is connected to the HMD through a wire, and for a given stimulus to be recorded as seen, the patient presses the button. The computing system then determines the test results with the recorded information. The test control device is a tablet that is connected wirelessly to the HMD, to the patient response pattern, and to the cloud server. The device is portable, does not need a dark room to perform the test, and can also be performed in supine position. To set up a test, the administrator initially logs in and pairs it with the headset, followed by input of details. The tablet has HMD details, settings, new tests, and reports. AVA offers white-on-white perimetry with a stimulus intensity that ranges from 0 to 40 decibels, and the test is performed with Goldman 3 stimulus size. The test details can be set by choosing the eye that needs to be tested, followed by the test pattern that is either a 24-2 or a 30-2 program, or a test strategy that can be either a screening, full threshold, an ELISA zest, or ELISA fast. Other details that are fed into the system include personal details such as patient's name, age, sex that help to retrieve the stored data, which is stored on the backend server. The clinical data on AVA is encrypted and is therefore secure. The eye tracking system tracks the pupil movement while the test is being conducted. Hence, it helps to check for fixation losses. The interpupillary distance can be adjusted. Refractive errors can be corrected. The printed test report consists of patient information, reliability indices that comprises of fixation loss, false positive and false negative, absolute threshold values and grayscale pattern, gradient plot based on defect significance, and global indices that are compared with a normative database built specifically for AVA. These are the various kind of visual field defects detected in grayscale pattern.
Wow, that was something else, huh? Just to change the mood now, we have a polling question for the audience. So guys, get your clickers on. And here it is, the polling question for you guys. How often do I use MIGS in my practice? This gives a heads up for all my moderators and speakers here to gear up to get the answers. Never. Am I comfortable with my trabeculectomy? 10%, 40%, 60%, and all the time. So can we also close this polling? And the answer goes to never. They're all comfortable with a trabeculectomy. You guys have a role to play, guys. All the moderators and speakers are going to change the mood of the audience now. So without any further ado, let's start the introduction video for the MIGS session.
MIGS session. The coordinators: Elizabeth Yu and John Berdahl. Featuring speakers: Malik, Kahook, USA. Emilio, Suzuki, Brazil. Lukan, Mishev, Bulgaria. And Sarah Van Tassel, USA. Organizers: Sergio Canabrava, Brazil, and Ashwin Agarwal, India.
All right, well, you guys heard it. The panelists, we've got a lot of work to do. I mean, domestically in the US, we know that MIGS has really grown what both glaucoma and comprehensive doctors are doing to manage their mild, moderate, and maybe even more severe glaucoma patients. With me, my name is Elizabeth Yu. I have Dr. John Berdahl, or I'm sorry, the John Berdahl, as my co-moderator for the session. We will be doing a great justice to MIGS space, going from all the devices through what to do when MIGS may not work. We're going to start with Dr. Lukan Mishev from Bulgaria, discussing device-based approaches to MIGS surgery.
Hello. Thank you, Sergio and Ashwin, for having me here and inviting me to present a case. Let me just share my screen. So this is a case of XN45 implantation. This is my routine way of doing it. I always use mitomycin C under conjunctiva because I'm sure that it helps the longevity of the implant effect. Then I made one side port 1.2 millimeters. I use cohesive viscoelastic to really open the angle where I will implant the IOL, and it will maintain the space in AC for maneuvering. My main incision is regularly 1.8 or 2 millimeters because this is enough. Here I remove the metal pin, then the plastic guard pin also. I must admit that the delivery device is really cleverly made. Now this is the introduction into the eye, and we should aim to the angle, and I often use the shape of the pupil as a landmark if I am on the right place. Here the pupil ovalized, so probably I engage the root a little bit. Then I will retract the needle and will approach the angle again in the right plane. And the good thing is that you should feel the angle. Now we pierce the sclera, and we need to look where we are actually going out under the conjunctiva. When we are sure that we are under the conjunctiva, we need to advance the slider slowly, and the most important thing is to not retract the injector before we ended injection. Otherwise, we will not implant the full length of the XN45. Then after the implantation, I use Ahmed DVX lens to see where exactly the implant is sitting into the angle and into the AC. Here we can see approximately 1.5 to 2 millimeters under the conjunctiva. Then we wash out the cohesive OVD from the AC. I like to do it with a small 2 cc syringe. Then I pressurize the eye. Now one should check if a bleb is forming. Otherwise, we need to prime the implant in order to be sure that it works. Now you see how the bleb is forming. I control the pressure of the eye with my thumb and gradually increase the pressure in the AC until I see bleb formation. Now this is anterior segment OCT movie, which shows the position of the implant. Where is implanted? Is it under the conjunctiva, or how are the relations with the tenon? Is there a bleb or so? I find the anterior segment OCT really useful in evaluation of the position of the XN45 implant. And this is a picture, again with anterior segment OCT, with a well-visualized XN implant. Thank you for your attention.
Thank you, Lukan. Very good. And next we have Malik Kahook talking about a goniotomy-based approach to MIGS. And Malik has been a good friend ever since I tried to get a job with him about 10 years ago.
All right, I'm going to go ahead and share my screen here for you. All right, great. I want to thank Sergio and Ashvin, of course, for the invite, and Liz and John for moderating the session. I'm going to talk a little bit more about the basics of doing goniotomy. I thought the video that we just saw gives you a great idea of some of the range of devices that we have. We tend to use Zen a little bit later in the course of treatment, and I'll talk about something we use a little bit earlier in the course of treatment. Just by way of introduction, I love talking about a couple of things whenever I talk about MIGS, and that's the fact that the most astonishing thing to me is this slide is what we used to have when I was a fellow and a resident. We would go from drops to laser to trabeculectomy without much in between, but now we have this entire range of devices and different methods for treating patients between drops, laser, and going to trabeculectomy. And now what we're struggling with is trying to pick which device would work best in which patient. So we need more data. I'm going to talk about the basics, and then I'll talk about the data a little bit. So incisional goniotomy is what we think of when we mention the word goniotomy. This was introduced decades ago by Barkan, who first used a gonioscopy lens to look at the angle prior to doing an incisional cut of the trabecular meshwork. This, of course, was through an ab interno approach, but it produced two leaflets that would often, especially in adults, scar back together and negate the efficacy of the procedure itself. So this is why we came up with doing an excisional goniotomy instead. I'm going to go over this just in basic terms, and I'm going to try and use my arrow here. Hopefully you can see that in picture one, the tip of the device goes into the trabecular meshwork, and then the key to the entire procedure is this ramp that elevates the trabecular meshwork up the ramp and towards these two blades. The two blades then create parallel incisions, which allows you to excise a strip of trabecular meshwork. We started off in 2013 doing some basic studies comparing an MVR blade, basically an incisional goniotomy, to the dual blade goniotomy. And what you can see here from our first paper is not just an incision without removal of the leaflets, but also injury to the scleral wall. Whereas with the dual blade device, we don't have the leaflets remaining. And of course, it's a safe procedure because of the footplate on the back side of the device. So here's my friend V. John Berdahl doing a case of KDB. I think this is his first case. You see he does have a little bit of shakes here, but that's his baseline, has nothing to do with the device. You can see going from left to right, creating this partial excision of the trabecular meshwork, and then from right to left. And I'm going to play this bottom video at the same time while you're watching the end. He basically goes in with duet forceps to remove the strip. But I would encourage everybody doing MIGS or angle-based surgery to do this fluid wave at the end of the procedure. You can see up on this side of the video the wave that removes the blood from the vessels. And that tells you that you've successfully unroofed the canal. And I often tell patients that I've seen success in what I tried to do. And now we can wait and see if the eye wants to lower pressure, but we've done our job for unroofing the canal. This is Paul Singh doing the procedure from right to left and then switching from left to right, just to give you an idea of how long this takes. And the skill set really is in the gonioscopy part of it, recognizing the anatomy, but much of the motion is stuff that we're familiar with as anterior segment surgeons. So who's a good candidate when you're doing your first cases? You want somebody who's cooperative, you want a good view, you want to make sure you can see the anatomy, and one trick is to use trypan blue to stain the trabecular meshwork. You can see that in the bottom right-hand corner here. And then you can pretty much treat any stage of glaucoma from mild to severe, and most forms of glaucoma that I'll go over here in a little bit. You do, however, want to avoid treating patients with active neovascular glaucoma or active uveitic glaucoma, patients with elevated episcleral venous pressure, poor angle view, and if the goal pressure is 10 or under, you're looking for something different like a trab or a tube to get you there. All right, so let's talk about clinical data here before wrapping it up. One of the things that we need to do more of in the MIGS or angle spaces is get more data. This is a prospective 12-month study done in 7 centers looking at higher and lower IOP and an average of the two. And what we see here is no matter where you start, so the high pressure 20.5, low pressure 13.1, and then the average of 16.8, they all end up around the same of 12 millimeters of mercury, and the adverse event profile is very, very low. The point here is you can get pressures to just about episcleral venous pressure if you excise about 4 clock hours of trabecular meshwork. Next study is just to show longer term follow-up. This is the only one that's public, I believe, at this point with 30 months, but we're out to 4 years in our data set showing that 69% maintained greater than 20% IOP reduction. 85% had a decrease in their drops by 1 or more at the conclusion of the follow-up in this case. If you don't remember anything else from this talk, remember this slide. Angle closure glaucoma is one of the perfect subgroups of patients that respond to goniotomy. You can see our pressure 25 to 13 drops from 2.3 to 0.14. If I have a chronic angle closure glaucoma patient, I'm thinking excisional goniotomy all the way, and you can see the data here support that. And I'll close off with one study here before a couple of points from our practice. In mild to moderate glaucoma with phacoemulsification, head-to-head, prospectively, iStent versus KDB, this paper just got published in JCRS. The primary outcome was pressure reduction greater than 20% or IOP reduction, IOP medication reduction of 1 or greater of their medication bottles. 164 eyes where 83.7% of the KDB phaco group met their primary outcome. 83.3% of the iStent phaco group met the primary outcome. And you can see on the bottom right-hand side, as far as pressure equal to or less than 18, the excisional goniotomy patients come on top with a higher percentage of success. So this shows that significantly more KDB or excisional goniotomy eyes compared to iStent bypass eyes can achieve success. And I think we need more of these studies. We need more of these head-to-head studies in MIGS. So I'm not gonna go over all the details here. It's just to say that we have a lot of studies, about 30 studies right now with excisional goniotomy showing success. And I want to close off with an academic thing. If you like looking at trabecular meshwork and trying to figure out what's happening with glaucoma, this is one of the rewards that we have from doing excisional goniotomy. We can take the trabecular meshwork and we can see what different devices are doing in the angle. We can see the pathophysiology of glaucoma in a way that we couldn't before. This is a case of an iStent that I had done 2 years prior. I noticed that there was a film growing over the iStent, pushing it down. So we went in, removed the iStent, and this is just me doing an excisional goniotomy. And towards the end, I can feel this resistance. And you can see a film that was actually growing over the device. And I'll point that out here, right there. You can see the film to the right-hand side. So we collected the tissue and we took it to the lab to do histology to make sure that we weren't missing something as far as what the pathophysiology was. And we published this in Journal of Glaucoma in 2018, just a couple of years ago, showing that all of the tissue, especially the trabecular meshwork around the implant, showed fibrotic tissue, loss of trabecular meshwork, loss of pigmentation. And this was consistent across all of the devices. We've done a couple of dozen of these to date, and we see exactly the same thing with each one. So there's something happening at the level of the angle when we put things in there that might be similar to what we see when we put a glaucoma drainage device under TNAs, just this encapsulation fibrotic tissue. And I think stay tuned, we're still doing more studies on this. In conclusion, excisional goniotomy allows you to excise tissue and expose multiple collector channels. No foreign body left behind, and you still have the opportunity to do conjunctiva-based surgery like trabeculectomy or glaucoma drainage devices. Implant-free, to me, is key. I try and do that as much as I can. It can be performed in combination with cataract surgery or standalone, mild to moderate to end stage, open angle, closed angle, primary or secondary uveitic or even chronic angle closure glaucoma, like I said, which is one of the sweet spots for this procedure. And now we're back like clinical data up to 4 years of follow-up with prospective head-to-head versus other angle devices, which is what I'm hoping to see more and more of as time goes by. I just want to leave you with a couple of links. This is my email address if you want to email me. A free wiki for educational material is keogt.com. And then this is my YouTube channel. So if you want to see the videos from this talk or other videos, please feel free to visit. Thanks, guys.
Dr. Kahook, thank you so much. That was so fantastic. One question that I wanted to ask you before we move to Dr. Suzuki. So you mentioned, some bleeding can be seen, especially with any kind of procedure they're doing with MIGS. Can you offer any pearls for our audience on how to control any bleeding intraoperatively?
Yeah, it's actually one of my favorite topics to discuss, because no matter what, we want both safety and efficacy. The safest possible procedure when you're doing angle surgery is to just do the phaco and get out, right? But if you're doing something to the angle where you're disrupting the trabecular meshwork, whether it's an implant, a device, goniotomy, whether it's a suture or KDB, you're going to get reflux if you've successfully done what you've aimed to do. So intraoperatively, what I tend to do is at the end of the case, I inject a little bit of cohesive viscoelastic into the angle, about 10% filling the angle right where the Schlemm's canal was unroofed. And I make sure that the pressure is increased to 25 millimeters of mercury with BSS. and I hydrate the wounds very well to make sure that we have stable pressure afterwards. So you can get the safety and efficacy if you just do those steps.
Oh, wonderful. Thank you so much. Now I'd like to introduce Dr. Emilio Suzuki from Brazil, discussing which MIGS to choose for our patients.
Oh, I having problems with sharing my screen here. Can you move on and I come later?
You have a green button behind.
Yeah, I see this. Okay, no, yeah, it's okay now. Okay. Okay, now I think you can see my screen.
We got it.
Excellent.
Okay, thank you so much. Okay. So first of all, I'd like to thank you, Dr. Sergio and Ashwin for this beautiful webinar during this pandemic. And Sergio used to call everybody as a boss, but really the boss is Sergio, is not ourselves. And Sergio, thanks for this invitation. And the theme I'm going to talk about is which MIGS to choose. I and Sergio, we work together in Brazil in the same city, and we share some experience. This is my disclosure. I don't have any kind of financial interest in this presentation or any device. So in the market, we have many kinds of devices or techniques to perform MIGS procedures. So we have trabecular bypasses, like a stent inject, hydros, and now we have the iStent wider. We have techniques and devices for trabecular ablation, like KDB, IBIC, and GAT procedure. We have no longer, but we still have the CyPass, and the iStent Supra is a device that comes in someday to reach the suprachoroidal drainage. So the suprachoroidal space is a virtual space that can be reached by this device, even though CyPass is no longer available. And we have devices to reach the subconjunctival drainage and the space, like it was mentioned in the first presentation, like Zen, gel stent, or in focus little tube to perform. So which MIGS we have to choose? First of all, we must answer that question: who is my patient? Who is my patient to know which MIGS I'm going to choose? So we have some formal indication with patients with mild to moderate open and glaucoma. Glaucoma is under control or not, it is an issue to be discussed, but basically patient must be at maximum pharmacological treatment so we can reach the decrease of medication. Age can be concerned, but basically we use it to perform this procedure in patients with cataracts, but for example, in GAT procedure, we can perform it in young people. Patient with cataract is the best option to perform the combination of these procedures. And in some countries, the standalone procedure is still allowed to perform only for glaucoma patients. So, but the bottom line of this slide is we must know the gonioscopy of this patient. Definitely, the gonioscopy is very important to see if this patient can be a patient elected to MIGS procedure. And remember that a good anterior chamber does not always have an open angle. So this is important to perform a gonioscopy in all patients that you think to go to a MIGS procedure. We have some advantage for this procedure, like Dr. Kahook told us. It's basically it's an internal procedure or micro-incisional approach. We have a minimal trauma and trying to put the eye in a normal anatomy and physiology again. So the IUP usually goes to teens values, like 13, 14, 16. But it's a high safety procedure. We have a very quick post recovery after surgery. Basically, it's a sutureless procedure and a blebless procedure. And the most important, in my opinion, is that we have a huge reduction of medications, and it is for a quality of life of patients is very, very, very important. When you have a high intraocular pressure, in my opinion, when we have to choose one MIGS, if you have a very high intraocular pressure and you want to do a MIGS procedure, basically I would choose Zen, procedure or an in-focus procedure. It's more likely to trabeculectomy. It's like a compact trabeculectomy or a tube a drainage procedure. And we have reductions to up to 41%, and very important number of medication to less than one medication after some months of procedure. If your intraocular pressure is not too high, or your intraocular pressure is under control with many medication, but you want to release medication for this patient, you have many kind of procedures. You must elect the procedure you want to. You have more experience. You have Stent, inject, hydros, KDB, ABIC, and GAT. So basically, when we compare this kind of MIGS, the literature show almost the same IOP reduction. And the number of medication is the consistent very low after all this kind of MIGS procedure. It also depends on the surgeon's experience. So in many countries, we don't have any kind of MIGS or many kind of techniques. So here in Brazil, for example, we have a stent inject, a KDB, and the GAT procedure. And also we must respect the regulatory license. Like here in Brazil, we are allowed to perform all kinds of these MIGS. These MIGS are allowed here in Brazil, and you must check if in your country you are allowed to perform this kind of procedure. Otherwise, it will be off-label procedure. So for me, the most important issue to elect and to choose what MIGS you want to go on is your experience, your surgery experience. Cost. When you talk about in developing countries like Brazil, for example, cost is very important. And during this pandemic, we see that the cost is much more important than you used to think about that. So definitely here, the GAT procedure is the most, the cheapest procedure we can perform for a MIGS. Thinking about MIGS procedure, GAT is unbeatable in terms of cost here for us. So you use only a propylene suture, and you go to stent the canal, as you see in this brief real life case. We have a 45 years old FASIC young lady with 19 intraocular pressure, 4 medication plus laser procedure with moderate glaucoma. And you see I'm reaching the canal, and I stenting with a propylene. You can use also a nylon, for example, but the standard technique is with propylene is easier to perform. And you know, here from public health care, no condition to buy a device. So after 6 months, we have 13, only 1 medication, and patient is very happy. And you can see, and I agree with Dr. Kahook, at the end of the procedure, you must pressurize the eyes to avoid hyphema and to avoid bleeding. This is very important when you proceed this, when you do this kind of procedures in ablation of trabecular meshwork. Okay, so we have here another case. Is a very particular case. Is because this lady studied about the glaucoma surgery. So this patient went to the website and studied about trabeculectomy, about the procedures, and he told me he wouldn't like to have a bleb in her eyes. So, okay, we have only option at that moment. We can perform a MIGS procedure, but I can't, you know, I can guarantee you a good intraocular pressure decreasing, but let's try. Okay. That patient had cataract surgery as well. And we put in this patient two G1, so the 2 eye stents, stent in the canal. And the intraocular pressure previous to the treatment was 34 with 4 medication, moderate to advanced glaucoma. And we put here two eye stents in the trabecular meshwork, in the canals, you know, in the canal. And after 18 months, we're following this patient, and after 18 months, we have 9 of pressure and using only 1 medication, timolol. Sometimes patient does not use the timolol, but keeps the pressure around 10, 11. And you see here, it was not a conventional case, but it is interesting to share with you. And finally, I have the last case here to show you is the traditional case. So this is the traditional patient I use to encourage to go to MIGS. You know, when you think, you have some patient that you think, well, is this patient only for phaco or only for, or this patient must go to phaco trab? So when you have this kind of doubt of question, basically this patient fits well to the phaco MIGS. Okay, so this patient we have an toric IOL. We have that intraocular pressure in the beginning, pre-medication, moderate glaucoma, and after the procedure we have the 12 with no medication, and we perform in this case the eye stent inject that it was allowed here. I used to use during the surgery this hands-free gonio lens. I like too much because we have the two hands to move the eye to make more easy your procedure. So even though this lens has not a good optical clearance, but it's easy to perform the surgery. So after checking the angle, I move on. I perform the eye stent inject, dimpling the trabecular meshwork and release it, the first one here. And blood reflux is quite normal during this kind of procedure, even though sometimes it can bothers you during the surgery, the blood. But you know, we are in high magnification system, in high magnification view. So sometimes when you zoom out, you see that that blood is not too much as you think in the beginning. And this is what convinced me to go more and more to MIGS. We have a quick recovery. We have a blabless patient. It's like only phaco. I can't believe it. We are not inclined too much to see patients with this kind of view after a trab, for example. And this is good for toric intraocular lens. You do not change in conjunctiva and scleral, okay? So this is a very good, it's a very good option for intraocular, toric intraocular lens. Well, moving on, we think in terms of in safety, MIGS is very safety procedure. So MIGS have shown few complications, and despite of this kind of intraocular reduction, IOP reduction, it's a safe procedure. So as MIGS have shown a great reduction of medication and quality of life must be always considered for a patient, we try to put some MIGS in an advanced case of glaucoma. So there is a Latin phrase, primo non nocere, first do not harm, but we can remember that sometimes bleb can harm a patient as well. So I presented last year a case of 12, let me see, I present a case of 14 patients with advanced glaucoma and cataract, and the IOP was under control with medication. So we need to go to cataract surgery, and why not to try to make a MIGS for this patient. And we performed this case and check the results. Before surgery, the intraocular pressure, the previous intraocular pressure was around 14. And after the procedure, 2 months later, it was 11. It's okay, it's not a huge intraocular reduction, but when we check to the medications, we see that almost all patients were under no medication for glaucoma surgery. And we have new perspectives for MIGS, is really to put these kind of procedures to stand alone, only for glaucoma, not to use the cataract as a vehicle to introduce this kind of surgery for our patients. So my final slide is that which MIGS we have to choose. It depends on what patient you have, where you live, what kind of glaucoma stage this patient is, the cost, if your system can support the cost for it. But most important for me is your experience. Your experience must be considered first. For example, in some cases because MIGS procedure is not an easy procedure in the beginning. You have a learning curve, you have to practice, you have to be good in gonioscopy, you have to be good in intra-operative gonioscopy. And I'd like to thank all of you, and this is my city during the pandemic, and no one is in the city. So we see the lake, we see the everything good with no people, everybody taking care of themselves. Thank you very much.
Thank you, Emilio. That was fabulous. And I loved your last slide that shows the proliferation of devices and procedures that are done with MIGS, but the trab and the tube is not dead yet, and we still need them. And so with that, we'll transition over to the incomparable Sarah Van Tassel to help us understand what to do when MIGS doesn't get us there.
Great, thanks, John. Thanks, Sergio and Ashvin and Liz. I can't share my screen until Emilio unshares.
Okay, so sorry.
Perfect, no worries. All right, I'm live. I've been charged with answering the question, which MIGS, what's next if MIGS doesn't get me there? And I think the short answer is a lot of good options. I have relevant financial disclosures. You know, as with all glaucoma surgery, the challenge with MIGS is that perfect surgery can still yield imperfect results. And I think there are a couple common possibilities. One is that you have a phakic patient who's been well controlled on drops, but really wants to reduce their drops and adds MIGS to their cataract surgery. And sometimes you're unable to achieve that goal. Sometimes you set a lower target pressure and you just aren't able to deliver on that. And once in a while, you can actually have even a higher IOP after MIGS than before, paradoxically. But the great news is, and I tell my patients this all the time, is that MIGS leaves pretty much all doors open. And in fact, I think perhaps the benefit of doing MIGS first is that very often this means your patient is now pseudophakic. And I prefer glaucoma surgery in pseudophakics. This means you can place your tube in the sulcus. Management of an anterior chamber, a flat anterior chamber, is much simpler. You don't have to worry about sending phaco-inflammation up through a filter. You have easy access to the ciliary processes for ECP. And now that they're pseudophakic, you have no risk of cataract development with transscleral cyclophotocoagulation or with MicroPulse. And I think really depending on what your goals are for this specific patient, that motivates your next steps. So are you trying to reduce drops? Are you trying to lower IOP? Are you trying to achieve some combination of both? When I really need meaningful and predictable IOP lowering, I tend to move in the direction of incisional glaucoma surgery. And I think what's interesting is that recently we've been talking about the explosive growth in the MIGS space, but now in 2020, I would argue that we really have explosive growth in the incisional glaucoma surgery space also. We have variations on a theme for the bleb forming surgeries, some of which maybe are sort of these MIGS plus devices, but I think a bleb is a bleb. And then we also have new glaucoma drainage implants, which is exciting. And I think potentially a great first option after failed MIGS is a gel stent. And I know that Lukan discussed this. Surgeons like this for the intraoperative versatility. And I actually prefer this open approach. And you might say, well, if you're going to open, why not do a trab? But I really think that the absence of a flap speeds your surgical time, your recovery time. And these MIGS plus type surgeries do still have risks. And I think that's an important thing to tell patients about. But I think the improved risk profile of these blood forming surgeries compared with traditional trabeculectomy potentially improves the spectrum of appropriate patients and also the spectrum of potential surgeons who are interested in performing this type of surgery. And I think there are still some major unknowns with respect to the gel stent in terms of the durability of the effect, the durability of the bleb, the durability of IOP lowering. Obviously to everyone, but to this group in particular, trabeculectomy really needs no introduction. I know it's the surgery of choice for many of you. And in fact, it's still my surgery of choice for patients with truly low target pressures and for patients with a low tolerance for needling, a low tolerance for failure. Glaucoma drainage implants are a great option because there's a diverse number of implants. There's increasing availability of various implants across the globe. There's new patch graft materials and techniques for not using patch graft, and also new closure techniques like using glue. And glaucoma drainage implants are great because they can workinize with scar tissue. They aren't starved by adding back drops. You can add a second glaucoma drainage implant and they're compatible with cycloablation. A word on reducing aqueous production. This is another great option that can potentially follow MIGS in the right candidate. And we have a number of ways to achieve this. All of these techniques have in common that they decrease aqueous production, and they all have in common their side effects also. The one that we fear the most and that can be quite persistent is that of inflammation. I really love endocyclophotocoagulation. You get to directly visualize the tissue that you're targeting. And because it is truly a conjunctival neutral procedure, it keeps the doors open for all future surgeries, which I like. Cochrane reminds us just last year that there's really no high quality evidence, and that is the case with all of the laser options. And then finally, we have MicroPulse and traditional transscleral cyclophotocoagulation. Historically, transscleral cyclophotocoagulation has been thought of as kind of a last resort, but increasingly survey data and panels are showing that surgeons are considering transscleral across the spectrum of visual acuities. And then we have the MicroPulse option in many countries, which is sort of a CPC light type technique. It has potentially a wider spectrum of appropriate patients. And I think the main unknowns with MicroPulse are the ideal parameters. This has been a hotly debated topic, and also the durability of the response, which is potentially a little bit less than our other laser options. But the great news about MicroPulse is that it's highly compatible with additional surgery and with additional laser. So I would say, summarizing sort of the spectrum of all of glaucoma surgery, MIGS leaves a lot of doors open, which is makes MIGS a great place to start, but MIGS doesn't always get you there. You have a wide variety of next steps after MIGS. And I think there are still some major needs. Several presenters have pointed out our needs for additional data, but in particular, we don't know much about sequential MIGS. Maybe a couple years from now, we'll be talking about standalone superciliary shunts as our next step. We definitely need more data in the sustained release medication category, both following MIGS and also potentially concurrent with MIGS. And we don't know much about the role of trabeculoplasty after MIGS surgery. Thank you.
Sarah, you cruised through a lot of great information there and put that concisely and in a very understandable way. And I was really surprised by the first survey question that we did, where 60% of people said, hey, not MIGS. And so let's just, we're gonna go through a few questions. We're gonna go through them really quick because we're a little bit over time. So we really mean that. We'll go through it really quick. But everybody give one tip for a beginner surgeon. Malik, you start.
Practice gonioscopy in the operating room while doing regular phaco, positioning the patient in the scope before you get to your first case so you know what you're doing.
Sounds good. Emilio, hot tip for a new surgeon.
Yeah, I agree with Dr. Kahook. Try to perform a gonioscopy during the surgery, but basically, when you perform a gonioscopy in your office, try to see the nasal part of the angle. Try to see the nasal part of the angle. It's very, very important. If you see the pigments, it's a very good condition for stenting the canal or even to ablation the canal. This is my tip.
Sarah.
I would say take care to make sure that your clear corneal incisions are truly clear corneal. I think for regular phaco, it's not uncommon to nick the conj, but that limbal blood can get in your interface with your gonioprism and be really frustrating as a new MIGS surgeon.
Lukan.
Choose your gonio lens and rehearse even on regular eye to see the angle with the preferred gonio lens.
As a non-glaucoma anterior segment specialist, I think MIGS is something that we certainly can do for those who have stable glaucoma and want to replace 1 to 2 drops, especially with ocular surface toxicity. For me, doing it in the beginning of the case, even though there is the lens there, if there's enough of an AC that expands, having that nice clear cornea is a great way to start. And plus throughout the case, because of the pressurization, any heme often it stops because it's, you have time on your side. But between at the beginning versus the end, I like the beginning of the case.
And I've got one, and that is if you're using a cohesive viscoelastic at the end of the surgery, if you put a little bit of dispersive inside your incision, then it won't come out in big globs. And so you can maintain your chamber a little bit better because the dispersive may ooze out for a new surgeon as you're maybe putting pressure on the anterior posterior lip of the incision. One more around the horn question. How often do you try a MIGS procedure first before going to a transscleral procedure or a blood-based procedure? We'll go back around the horn. Liz, how often do you try MIGS before going to something transscleral?
100%. I don't do transscleral procedures.
Sounds good. Lukan.
When SidePass was available, probably it would be my first choice. Now, Stent is BLEP-related procedure, so it's MIGS plus procedure.
Got it. Sarah?
I think in angle closure, I'll try MIGS first almost every time because I really just believe in getting the lens out and opening the trabecular meshwork. But in POAG, if it's fixation threatening or there are pressures above about 35, I typically go to incisional first.
Emilio?
Yeah, I agree with Sarah. Very high intraocular pressure, I would go to trap and close angle trap as well. And I would like to change you. If do you have any kind of patient? Do you go to transscleral procedure as first choice?
Yeah, that's kind of my question. Which one does it? So let's push that to Malik. Malik, how often do you do MIGS first, and which patients do you do transscleral first?
So this is a common question. It came up on the Q&A as well. And more we're doing angle-based procedures and telling the patient, especially those who are at high risk for failing at MIGS, that, you know what, they have a 50-50 chance of succeeding. And if they do, then we can get away from a bleb for many, many years. So whenever possible, I take a shot at angle surgery before, unless it's what Sarah said, a 0.99 cup, split fixation, I'm really worried, then I go to trab or a tube. The one thing I'm going to add, just because I know we have a lot of time, is that patients who failed a trab or failed a tube, you can still go back to MIGS in those patients. We still get home runs and failed trabs, failed tubes if you do a goniotomy or if you combine with ECP. So really, MIGS is here to stay, and we have to figure out where it fits, and I think it's going to be in multiple places.
And just so that I answer my own question, I'm probably 95% plus of the time try MIGS first. You know, as doctors, we've got this beautiful question we can ask ourselves, which is what would we want if it was our own eye? And if you do that and you watch them closely and they progress, we can move on to something more aggressive. And if something, you know, unfortunate happens, we feel good that we tried everything that we could. Liz, do you have any other questions for this honorable group of people?
One popular one was what kind of gonioscope is being used intraoperatively? If we could just go around and have them answer for those who aren't performing MIGS currently intraoperatively.
I use a Volk.
Yep, I use a Swan Jacob.
I like Hill and the Securiflex vernacular, the hands-free gonio lens.
Swan Jacob for me.
For Rango, Volk, or for Stent, Ahmed DVX.
And you mentioned with the Ahmed DVX that there's no tilt necessary, is that right?
Yeah, exactly, you don't need to turn the head and the microscope.
Wonderful.
One last question from the group that was asked was, won't simple cataract surgery decrease IOP by 2 to 4 millimeters of mercury? I think the answer is yes. It just doesn't have the same duration. That usually lasts about 2 years. And the other thing that should be known about cataract surgery and at least angle-based MIGS procedures is generally speaking, the higher the IOP, the more impressive IOP lowering you get, and they settle out at kind of a new baseline. And so understanding that data is really helpful. And then I just have two parting comments. One is when I was in residency, which despite the gray beard wasn't that long ago, I was taught that angle-based procedures don't work in adults. 10 years later, it's the most common approach to glaucoma surgery. We need to continue to challenge our own thinking and challenge our own dogma, because the world's a better place, and look at all this proliferation of treatments. And then the other thing that I'd just say, despite all the upheaval that we have in the world last night, or right now with the pandemic and, you know, different things going on in the world, is last night when I looked up at the stars, the International Space Station went over, and it reminded me of what was happening today. And how one good thing of this global pandemic is it's kind of uniting a global group of people, and we have thousands of people from all over the world here together learning for each other, and we're just humans, you know, trying to help humans being better humans. And I want to thank Ashvin and Sergio for bringing us all together.
Thanks.
Thank you so much to our wonderful faculty as well. Thanks.